Thank you, Subin, for involving me in this very interesting instruction course. And we have been together in so many other areas, and wonderful to have friends like you.
Privilege, sir.
Yes, you rightly said. Small pupil does give a lot of challenges to a surgeon on the table, and subsequently managing these patients in a post-op period also. No financial disclosure from my side. Looking into small pupil management, I think it starts right from a pre-operative time because you have to optimize your pre-op dilatation, and adding NSAIDs makes a lot of difference for these patients with a small pupil. So you can have a pharmacological agents or intraoperative techniques to manage these small pupil. That is what I'm going to cover today. Rest, the important part will be covered by subsequently by Subin and other people. So this is we recently did a comparative study to look into a use of NSAID, especially bromfenib 0.09%, a single dose which has come now in the market, and comparing that to a double dose. We did a Equus analysis for these one and or two daily dose for these patients, and we knew that both the single dose and double twice a day dosing was effective to prevent intra-op meiosis happening in these patients, and the pain in a post-op period was well controlled. So we knew that NSA does work, but single dose bromfenib is also wonderful in such case. Sometimes you look into intracameral solution because you need to inject something to dilate pupil and maintain the dilatation throughout your surgery. You can combine phenylephrine with lidocaine in this combination, or you have a simple intracameral epinephrine or epitrate, which also gives a good dilatation if you add into the BSS bottle, which is 500 ml. So one in 1000 is standard dilution for epinephrine, which can be zero point 0.5 cc in a 500 bottle, which is a very insignificant to cause any complication to endothelial damage or subsequently you will damage to other CME happening in these patients. Sometimes you can look into other areas. You can have combination of injecting intracamerally directly a lidocaine preservative free 0.75% alone, or in combination with epinephrine. And nowadays you can add even a tropicamide also with a new combination which has come. High molecular weight viscoelastic is definitely helpful in most cases. I'll just show you one video. This is I call it a flutter sign, which gives an assessment of how floppy the pupil may be. So this is around 5 millimeter dilatation, which is sufficient for a phaco procedure here. So all side port and main port, no aqueous leak, therefore no flutter in the pupil. Just see when I go with my cannula with the viscoelastic. So that is the time where you can have, just see here, that will tell you what type of pupil we're going to face here. See this flutter. So this pupil is not rigid. So you require some sort of intracameral medication to make it rigid pupil so that it maintains your rigidity throughout the surgery. So under the viscoelastic cover, I'll inject epitrate 1 in 1000, just little bit, and see how beautifully pupil dilates. And this will be maintained throughout the surgery. So this flutter tells you how much will be the floppiness. If you have a floppy iris like IFS, then the floppiness will be so much the pupil, the iris comes towards the wound area and thus tells you how floppy it is. In those cases, you may require devices to maintain your intraocular procedure. So this is one patient. The pupil is around 2.5 millimeter here. And you can see this is a totally unedited video, which will be finished in time, I believe. I made the side port, and the pupil is absolutely stable. This indicates this pupil is may not be floppy at all, despite having a small pupil. The floppiness doesn't go with the pupillary size on the table. The floppiness comes subsequently when we intervene. You can see now I'm injecting a viscoelastic. There will be no flutter in the pupil here. So this is a reasonably rigid pupil, and this is a viscoelastic dilatation of pupil. So it comes to around 3.54 millimeter, which is sufficient to deal with your routine surgery. So I'll be doing a rhexis of around 4 millimeter plus size in this case. The routine side port rhexis here, going from center to periphery, and make sure your viscoelastic doesn't leak out. That is very, very important. And flatten the capsule as possible. Be little towards the edge of pupil, which is around 4 millimeter. If going little beyond the pupil, will be around 4.5 millimeter axis. The rotation and ease of flap going will make yourself confident that your axis is not going to periphery. And always steer circumferentially and pull towards the center, as you saw towards the end, that completes the axis here. All small pupil, because you are not seeing the axis margin comfortably, your hydro procedure may be little difficult. So that, but again, you have to try to do a good hydro dissection so that nucleus gets free. So I'm doing a hydro dissection here from two sides, and that will make sure the pupil is should be not damaged at this stage, of the pupil constricts to almost small. But in the beginning, I saw this was a little rigid pupil, so nothing will happen to the pupil here. So I have around 2.5 millimeter pupil. This viscoelastic will again enlarge the pupillary size a little bit. So using a high viscosity viscoelastic is very, very important. A little bit of soft shell technique makes things easier for you, and you can do a good phaco without damaging the endothelium in such cases. I'll go with the parameter, which is basic for me, around 55 IOP. Now I have gone back to 45 IOP now. Moderate aspiration, flow, and vacuum for this patient. Around 300 will be my vacuum, and 34 or around 40 is my aspiration flow. I'll remove all the free cortex over the nucleus here. Then subsequently manage the nucleus by doing a chop. So that is important to have a slightly deeper bulk being picked up so that you can have a good chop here. All difficult cases like a small pupil, direct choppings can be difficult sometimes. So I'll make a little bit of a shallow trench so that I can hold good here. Then chop. You can see the chop is quite effective here. Because the hydro procedure was not complete, you can see rotation is difficult. What to do at that stage? Make a small chop, take out this pie of nucleus. This will make sure you have more space for a nucleus to be tilted or rotated. You can see now I'll try this particular part here. If that is rotating or not, it's still not rotating comfortably. I'll take one more pie from here. So this is a trick for all those cases where you don't have a good hydro procedure, where nucleus is not rotating. This is how you manage comfortably in a difficult situation like a small pupil. Once I have removed half of a nucleus, maybe the fluid has seeped in, and you have an internal hydrodelineation happening in these cases. The nucleus can be rotated or sculpted, catapulted towards a central area. Now you can see, you can rotate the nucleus here. That is how you manage cases without having a good, comfortable hydro delineation or hydro dissection. So this is how comfortably I have done a phacoemulsification, completing the last piece of phaco here. Subsequently, epicortex will be difficult in all these cases where hydro dissection are not complete and a small pupil. There, I think IA or a bimanual IA will be very effective to manage such cases. The last piece has been taken away. Then I'll use IA for removing this cortex. Make sure you don't touch the pupillary margin, otherwise pupil will constrict. See the greatness of this pupil. It remained constantly same size right from the beginning of procedure towards end of procedure. And this end of aspiration, I'll be injecting IUL now, and you can remove the viscoelastic subsequently. So this is to show you have to differentiate the different types of pupil on table. You can see I can just see the axis margin here. Once you dilate with the AC compression, you can see the axis here. The surgery is complete. To summarize, I think NSAIDs works very beautifully to maintain the pupillary dilatation throughout your surgery. This should always be used for all cases of phaco surgery, and always try to identify rigid versus floppy iris with the flutter sign. The amount of flutter will decide how much floppiness would be there for that particular pupil. Intracameral epitrate or adrenaline can be used. That should be used preservative free if possible. If you don't have, then you can dilute them 1:1000 and inject underneath the viscoelastic cover. Always use high molecular weight viscoelastic, which will maintain the dilatation. Maybe moderate low fluidics phacoemulsification, and use bimanual techniques, especially for epicortex removal, because you have to go underneath the iris and don't try to catch the stroma from behind. Otherwise, you'll have a lot of iris atrophy in these cases. Thank you, Subin, for involving me in this particular course. It was wonderful speaking in